through the miracle of Slido, already questions from you, both in the room and those of the 700 joining online. And the first one I'd like to ask is, could each of the panel reflect on what they consider to be the biggest challenge ahead for KHP partnership working, and what is also the biggest opportunity? So a brief reflection on each, if I could, and I'll go straight from left to right here. Ian, could you start?
Well, Charles, thank you very much. Clearly a time of opportunity, but also challenge. What I'd suggest are three things. First, we have an opportunity for a new compact, and a new compact from patients really to populations, recognizing the importance of the individual, but really looking to influence the many to a healthier future. I think we need a significant ambition, partly reflecting our ambitions in translational medicine, to go from what is effectively at the moment a salvage disease system to a concept of health sustainability, and effectively from intervention to prevention, and then to take a new model and the opportunities, again, that have been touched on this morning, Charles, from analog to digital, and really to create a health system without borders. So those are ambitions, opportunities, but recognizing the challenges that I think the KHP organizations and the partnership are very well set up to deliver.
Clive.
Yes, I mean, I think the issue is I think the opportunities and the challenges are in many respects one and the same, really. And I think we have to make sure that our translational research in particular is relevant to the populations we serve, that it's meaningful, and that it's digitally enabled. And I've no doubt we'll spend the next 20 minutes or so talking about how we make that happen. But there is a limitation in terms of time and resource and capacity across both the academic and clinical sector. And so to focus on those three elements and maximise the utility of our research is critical to improving the overall health and well-being of our citizens.
Thank you. I'll go to David and leave the last word to Shitij.
Right, thank you, Charles. So I would say the biggest challenge that we've got is in child and adolescent mental illness. And there have been record numbers of referrals to services. Prevalence has massively increased. COVID hasn't obviously helped and has contributed significantly to this. And we heard from Grania earlier on about the majority of mental illnesses start in childhood. So for us to be able to have a real impact on that, I think, is conversely from saying, well, the biggest challenge to the biggest opportunity here. And with the development of the new PAIRS Maudsley Child and Young Persons Centre at the Maudsley, which is a KHP development. It is KCL, and Shitij was the very the start of this and really the vision around some of this. The development of that centre, and it's coming online now, really has the potential to change this picture. And we have got some of the best people in child and adolescent working in this. So clinicians, academics together, and really contributing to this. So I think that is on the one hand our biggest challenge, but is one of the biggest opportunities for KHP going forward.
Thank you.
Well, there's not much left to say at this stage. So here is what I would say. I think the challenge is not just for KHP. The challenge is for the entire health enterprise, and it is the following. I became a doctor in 1988, and every decade, life expectancy increased by 3 years. It was a golden time to be a physician. Last 5 years, that has stalled. In the United States, it is going backwards. I could not have imagined, with all the advances that happened, that life expectancies in the Western world, stalling, yes, going backwards. So I think this is a serious challenge. It's a challenge about the orientation, the way we are looking at health, and it's also a challenge about the technologies that we are using. I think the challenge for KHP is to decide that in this vast ocean of challenges, what are the few finite things it will take up where it can become the world leader such that the world looks to us? Now, that isn't going to be easy because you would have seen the wealth of things we can do, but I think the challenge will be deciding on a few that we do so spectacularly well that people come here to see, not just read papers, that's easy. When people come to your institutions to see how you do it, to me, that's the real accolade, if you might. So,
Very good, thank you. I'll stay at the general question level, and then we'll move to some more specifics that that I have received here. And this is a question which goes to the heart of what KHP has been involved in since the beginning, as I understand it, which is, what is your vision for integrated mental and physical healthcare, and what is a realistic timeline to achieve it? This is the mind and body question, and who would like to go first on that? I think Shitij, would you like to go first? And
thank you.
and then I will ask one of the three chief executives.
Look, it's easy to use words like holistic, and it's easy to use words like entirely integrated. But I must say I've been sobered by 3 decades of practicing psychiatry in 4 countries. These things are rather easy to say. Often you find that your systems and disciplinary training militate against it. Our corporations are structured in a different way. If you're in the US, funding flows in a different way. So I would say that the vision for KHP should be seamlessness. So there should be seamlessness. It is very easy to say everyone will do everything and won't never happen. I think if we can just make our system seamless, which would go in the following way. First, the data should flow seamlessly. In other words, as an individual is moving across aspects of our system, their physical and mental data should move seamlessly. Secondly, expertise should move seamlessly. If we can do those 2 things within KHP to start with, believe me, the world will come here to see how we're doing it. Not easy to do, even though we're all agreed and we're all sitting in this room.
So just add on to that, absolutely. I mean, why we disconnect this, the mind and body. We don't operate as 2, do we? We know the impact that the mind has on the body, and vice versa. So the real making that separation, stopping that separation is something that we have to. And we are probably in the best place anywhere for this. There is significant work that goes on. We're separated at KCH and SLAM just by a main road. But so it's almost together, and there is fantastic working that goes on. And the Mind and Body programme is the envy of lots. And I don't think we celebrate that enough and really take advantage of it enough. There are over 1,000 people trained in this together, and it really is, I think, another one of the challenges that we have. And I don't think the timescale is long, really, of how we get this out further and further. So I think it's here, Charles, now, and it's how we make that take to the next stage.
Can I just add one thing to support that last comment from David? So when I came down to King's about 5 years ago, I was really blown away, actually, by the way, certainly, for example, in haematology, clinical psychological support was embedded in the service. I mean, of course, COVID has not helped in terms of this expansion, but I think we are a real pioneer of this, and we need to really kind of spread in a really positive way very quickly. It's a very impressive arrangement we have.
If I may, I'll move on to a more specific question about clinicians themselves, which is, the question is, how can we better ensure clinicians who input data see the impact of their contribution, and how can we support clinicians to embed a research awareness approach to their daily practice? Ian.
Yeah, thanks, John. Well, I think the first way of answering that is that we have to give all clinicians across all specialties, the multi-professional team, the tools to do the job. And certainly I think we are starting to see the early shoots of that. So the significant investment that we've made across KCH and GSTT into EPIC, as well as the expertise that exists within SLAM and CogStack, and James has already referenced some of that, really to give those tools to clinicians, really to give analytics at the bedside. And bedside analytics has got to be the sort of future of how we approach things. We have insights, we have a lot of data. I think the other question really, Charles, is also about how do we go to what you might describe as actionable insights. Insights by themselves are sterile. We need to work out how we're going to more rapidly take the understanding that we have from the data and change things in real time. But I certainly agree with you, we need to move to a new era of clinician analysts.
And if we do that, there's a question here as to how do we marry the aspirations of seamlessness and being a pioneer on mind and body with the reality of our service provision, where we have limited funding, long ED waits, poor recruitment, and low staff morale, is the question that has been put. And I think that there is another question which I can link to that, which is how can we apply the lessons learned from a successful co-production at the BRC to projects and research across the wider work of trusts and KCL? They're two slightly different questions, but they do link into the lived experience of clinicians across the trusts and the university. David, have a go first.
Okay, so the complicated questions, aren't they, and difficult ones? But
That's the point.
I know it is the point, Charles. Yeah, absolutely. But I would give an example of something, and something if you were here last year, you would have seen, and the ability of data that we've developed and using that data in a way that does help clinicians we call it a viewer platform. It's CogStack, essentially. It's bringing together records. And you can absolutely see there where illness is situated in local populations. So of the thousands and thousands and thousands of records, we can see exactly where people who are admitted for psychosis or have psychosis live. And I think that's the way forward around this. Then how do we start to plan our services? Because at the moment we have teams all over the place. Why aren't we focusing on this? These are the real areas where this is the real prevalence of disease, and focus on there to say that's where we're going to put our resources, and that's where we're going to target staff, rather than we've got difficulties in recruitment and as the questioner said, but we use that data in a realistic way to help us plan and deliver services a lot better. And you can see that rather than paper-based records and people remembering, it's there. And it's a real example of how we can use data to the betterment of both staff and patients.
Okay.
Yeah, I'm happy to. So I think so. It's a really good question, and it's a really important question. The specific issue around challenges and priorities and competing priorities and finding time. And I think we have to have, a bit of a paradigm shift really, in that research is not just for the few, but it is part of what we all do as clinicians. Now there will be some what I might call proper researchers, for example, not people like me, but proper researchers who really are leading and driving, and we've heard from a few this morning. But every clinician, through the way in which we are enabling digitally our staff to work. So, as Ian has alluded to, only a week ago, we implemented the largest single instance of an Epic electronic health record in the world. And only within about 5 days or so, 30-odd thousand users have logged in. There's something like 30,000 patients have accessed their charts, their records online already. So the potential for every single clinician to have at their fingertips incredible and rich data which will allow them to participate and contribute to research in its much wider sense should then allow them more readily to be able to see the fruits of their clinical labour. If we carry on separating out clinical practice from research, I think we'll carry on going down the route where this just belongs to other people.
Ian, do you agree with that?
I do, but building on those points, Charles, I think one of the things that we have the opportunity to do is really take the capabilities of a world-class university, more broadly perhaps than the faculties of medicine and life sciences, and think about the other capabilities that we have in this great university, and perhaps make sure that we're introducing the totality of our workforce to the breadth of capability in the university. So we have real depth and skills, for example, in the social sciences and humanities, in law, in strategy, and actually making sure that it may, of course, we've heard that the lung and the skin are the most important organs. Actually, it's the kidney. But actually but really recognizing that we are a multi-faculty university and we're a multi-purpose health system, and really trying to marry those things together. There is, as Clive has said, research is for all of our patients and all of our staff.
Okay, questions are coming in from all over the place. I can tell I've got this machine in front of me. But somebody, I think, has been reading my mail and of what I've been talking to our chief executives about recently when they say it is Richard, not you, but another Richard, saying, do you think we are being brave enough? Current models of health are failing everywhere. Should we explicitly commit KHP's mission as leading redesign in a way that combines research, policy, and delivery, including the whole power of the university, but admits today's approach is unsustainable? Shitij.
Yes, I think it's very easy to admit that today's approach is unsustainable. The question is, what are you going to do about it? The question is that you do have immediate responsibilities, as my colleagues will go back to their work and look at their emergency rooms. So we have to find a way that we transition at pace. We're sadly not in the business where we'll stop this, take a 6 months break, and come back with a redesign. So I think in many ways your conference is hinting on the two main changes that we can do. And one is a shift in our orientation to the population. And the second is the incorporation of the new technology of digital into everything we do. Now, the challenge is, how does one do it at the system level? Interestingly enough, you do it at a system level also with small pilot examples that are successful. So there is no way we can simultaneously do it for every disease all at once, because we just don't know what the right model is. So my hope for the KHP would be that the next time we meet, that we have somehow brought together population and digital in maybe 3 places where we have special expertise and tested and demonstrated some success. I think we'll have to build on it that way. I wish someone had a blueprint somewhere to transform the system tomorrow. I can tell you, the pleasure of having worked in 4 countries is that no one has it. Everyone's struggling with it. So I think we have to find our pilots where we can show success.
Clive.
Yes, I'd agree with that approach. I think the other point to make is, and we're going to have to be really brave in this really difficult world to do this, we're going to have to try and double run. So we are going to have to try and double run it. We get into the situation where it's either or. Either we do research or we carry on with our routine clinical duties. And we are, in a number of areas, I think, we are going to have to accept we have to run a couple of 2 or 3, whatever we choose in terms of pilots, in parallel to hopefully prove that we can, by adopting a new way of working, a transformative way of working across the entire system, we can get, this left shift. We can move relatively more to prevention rather than treatment at the end of the pathway. But that is really difficult, it's challenging, and it's been, of course, made even more so because of the impact of the pandemic.
I've got time for two more questions. One is, what is the opportunity for KHP from the integrated care system, and do we have relationships to capitalize on this? We now, the integrated care system is clearly establishing itself as a norm across the NHS. And second question is to do with people, which I think it's extremely important that I hear from the panel about. The question is, how can we make KHP an attractive place to study and train? How is digital and new forms of technology making a difference? And I would like both of those questions to be addressed, if possible, starting with you, Ian, please.
Well, if I take the second question, an attractive place to work is one being a place that does, not just says, that we are committed to inclusion and fairness, that we do start to think about new models of care, partly answers the last question, and that we are brave, as Clive has said, to take some of those double running opportunities, and to put the tools of the fourth industrial revolution in the hands of our staff. In many ways, healthcare is still an undisrupted industry, and there are now tools that we can do things differently. And I think we have to be brave to do that, and we can, I think, within KHP.
Clive.
Well, in the interest of time, I'll be quick. So I think we know that in terms of integrated care systems, one of their 4 priorities is the development of population health. And I think in order to support the integrated care system, the ICS is in that. KHP needs to sit at the heart and be an integral part of the ICS in South East London. And I think people are struggling to understand quite what the ICS is all about. Well, it's called integrated for a reason, and I think we do at KHP have to integrate even more than we have before to provide support for and behalf of the ICS, the whole agenda in relation to population health. But more than that, we need to move away from any idea of silo working. Those days should have long gone, and we need to maximise all our assets, both in terms of manpower and physical, to make sure that we do the very best we can with the relatively limited resource we have.
David.
Yeah, I absolutely agree, and I guess the ICS, some of us are part of it, so we have that key real link into that. But and as Clive says, one of their main remits is the improvement of population health, and I don't think there's many other ICSs across the country that have the full capability and capacity of King's Health Partners, the university, and all of our infrastructure within their system, and how we leverage that together to improve that. I think what's really important to remember as well is the ICS, Clive said it's integrated with social care as well. And what we don't forget is that social care element and the social determinants of health and how we influence that, not just think it's health in the world that we know it. And so it's really important not to neglect that.
Shitij, and then I'll wrap up.
Right. So I'll actually give you you raised the issue there. How do we, in some sense, engage with this word of data and AI? So let me tell you practically how you can do that. We realized that this was a challenge. We realized that this is not a tool that people at the top will understand how to use and then teach people in the trenches what to do with it. It's quite the other way around. So what we've decided to do at King's is actually publish the principles and teach people about the tool and let them apply it with the guidelines of ethics and integrity. So we've developed a course. It's called Generative AI in Education. It's freely available to anyone within the King's College London, and Richard, as in Professor Trembath, will make sure that it is available to all of you in King's Health Partners. Now, that is, however, focused at generative AI in education. It was developed over this summer because the privacy and confidentiality constraints in education are a bit different than they are in healthcare. My hope and ambition would be that in the next 6 months, we provide you such a tool as to what you can do with it in healthcare. And then you go and experiment. Because as I said, this is not the kind of technology that people on the top will figure out how to use and tell you how to use it, because its uses are so diverse. It's the technology you should know how to use safely and then tell us what are the good ways of using it. So what I can tell you is one element of it, generative AI in education, is already published. It's on Future Learn if you wish to buy it, but you don't have to buy it. If you're a part of King's Health Partners, we will make access possible for you for free. But I think we should commit to having something like this. And James Teo gave you a good example anyway, for King's Health Partners within the next 6 months, so you can use it across King's Health Partners.
Well, thank you very much indeed. I'd like to thank those that in the audience here and online who've submitted questions. I apologize, we have not had time to consider a very large number of extremely interesting and quite specific questions that we have received. But I hope that you have gathered from the leadership team in the conference that KHP is ambitious, it's collaborative, it's led by science, and its mission is to improve population health. And if we've conveyed that message, then I think we've done. It's a question of how we all work together to achieve those goals. So thank you very much.